Thank you very much for the opportunity to present our work. My name is Boris Zevin. I'm an assistant professor of surgery at Queen's University. I have no relevant conflicts of interest to disclose. The objective of our study was to examine the effect of adding a 29-slide interactive video supplemented module for laparoscopic Roux-en-Y gastric bypass procedure to a standard verbal consent. We examined the following outcomes of interest: patient's immediate and delayed retention of procedure-specific knowledge, patient satisfaction with the clinical encounter, and duration of face-to-face time required for the surgeon to obtain informed consent. The digital education platform was a 29-slide online module that went over risks, benefits, alternatives, and expected outcomes for the procedure of choice. Patients had to confirm understanding for each slide before advancing to the next, and we had videos embedded into the module. We conducted a prospective, non-blinded, randomized controlled trial at a single bariatric center of excellence in Ontario, Canada, between December of 2018 and 2019. The inclusion and exclusion criteria are available on the slide. We had 51 eligible participants who completed the baseline assessment and then were randomized into the intervention arm, which included exposure to the digital education platform, along with the standard verbal consent, versus a control arm, which included standard verbal consent alone. Post-intervention assessment included a 20-item multiple choice procedure-specific knowledge test, a modified client satisfaction questionnaire, and duration of time required to obtain consent by the bariatric surgeon. We then had a delayed assessment of procedure-specific knowledge in 4 to 6 weeks using the same 20-item multiple choice test. There were no differences in demographics between the groups with the exception of sex. When we examined the knowledge assessment scores, we saw no difference at baseline. However, following intervention, participants who were exposed to the digital education platform scored significantly higher on the multiple choice test versus those that were in the control arm. The Cohen's effect size was moderate at 0.72. When we looked at within group changes in knowledge from baseline to post-intervention assessment, participants who were exposed to the digital education platform had a significantly greater improvement in their knowledge versus those in the control arm. When we looked at the delayed retention of knowledge at 4 to 6 weeks, we saw that there was no difference between groups. However, both participants in both groups scored over 80%. When we looked at the duration of time to obtain informed consent, we saw that participants who were exposed to the digital education platform spent significantly less face-to-face time with the bariatric surgeon, with a large Cohen's effect size of 1.92. Despite that, participants in both groups were equally satisfied with the clinical encounter, and 90% of participants in the intervention arm were satisfied with the digital education online module. As such, we were able to demonstrate that addition of a digital education platform to a standard verbal consent in bariatric surgery resulted in superior acquisition of knowledge, equivalent patient satisfaction, and 50% time savings for the clinical encounter. Thank you very much.